Welcome to Patients at Risk. I'm your host, Dr. Rebecca Bernard, and today I'm being joined by Professor Arthur Caplan. He's talking with us about a point of view that he published regarding the use of doctor by non-physicians in a clinical setting. So tell our audience a little bit about your position on who should be called doctor in healthcare.
Well, I have a PhD. I don't have an MD, although I did go to med school briefly before I abandoned ship and went and got a philosophy PhD. But I would never, in certain settings, refer to myself as a doctor. If it's a clinical setting, a hospital setting, a nursing home, a clinic, I'm not going to call myself doctor because people immediately assume, patients, that you are a physician and that you have a license to practice medicine, prescribe medicines, carry out certain activities that are unique to what trained MDs are permitted to do. In settings of healthcare, I think it's wrong for anyone other than an MD to refer to themselves as doctor. And I know people sometimes say, well, what about your dentist? They sometimes use the term doctor, and sometimes they do. I've heard that. But they, I think, are clinical practitioners. And I think when you're at the dentist, you're not fooled by or deluded by the dentist calling themselves a doctor. So for me, to be clear, the moral principle is I don't care what nurses think. I don't care what social workers think. I don't care what bioethicists think. What I care is what patients think. And what patients think is people call themselves doctors or MDs. And so when you're around patients, when you're around people who are seeking care, that's got to be the line for me.
Nowadays, most nurses that go on to do advanced training, they're less and less getting PhDs unless they want to go a teaching route. More often, what we're seeing is this new concept called the doctorate or doctor of nursing practice. Have you heard much about this new degree?
Well, I have. In fact, one of my former students, Mary Mundinger, helped promote the degree. I had her in class when I was at Columbia, one of my first teaching jobs, and she was there and stayed there and eventually became the dean of nursing there. So I know quite a bit about it, and I know a few things. One is it's great to have advanced study. I'm certainly all for that. I think it's very important to respect what nurses do. Many patients will say they like and admire their nurses as much or more than their doctors, depending on how sick they are and getting taken care of by them in an ICU or in a situation where they're really dependent on the care that nurses provide. I also know that that degree is varied. You can get it online, you can get it in person, you can get it in 2 years, you can get it in 4 years. It's not particularly standardized. So that bothers me. I'm not against, again, people doing advanced study and respecting that work when it gets done. But that Doctor of Nursing Practice degree isn't quite the PhD, even though it has the term doctor in it.
Some of our DNP curricula are really pretty lightweight. And I'll show on our video a screenshot of St. Louis University's Doctor of Nursing Practice curriculum, which includes hours on healthcare policy, interpersonal collaboration, clinical informatics, leadership in healthcare. These are what I would consider more of the soft sciences. There's certainly not a lot there as far as clinical practice of medicine. And it's so interesting that you talked about Mary Mundinger, because as you said, she really was one of the main people that endorsed this DNP. And then more recently, within the last few years, in 2019, she published an article saying that she was concerned about DNPs because only 15% of the current programs are actually clinical in nature. So most of these doctorates are not providing a clinical focus, which even strengthens the argument you want to be called a doctor because you're doctorally prepared, but yet your doctorate really is not necessarily helping you to actually practice. I don't even know what to call it because you can't call it practicing medicine. They would say practicing advanced nursing. And now the new spin is to say we're practicing healthcare. So talk to me a little bit about your thoughts on that. What should a nurse practitioner say? Are they practicing medicine, nursing? What is it?
Oh, I think they practice nursing, and I think they practice healthcare. And I think we kind of reserve medicine for the practice of what doctors do. So part of this is you have to respect what everybody does. And I do. I'm in clinical settings a lot. I get called in for case consultations, talk with families who are fighting, sometimes get into battles between doctors and try to resolve them and that sort of thing. It's a nice skill. It's in healthcare, but it's not medicine. It's practicing bioethics, if you want to call it that. I think that if we understand that physical therapists do important things, that social workers do important things, chaplains do important things, we don't have to dub everybody a doctor to give them the respect they deserve. It's a complex healthcare system. Look, I spent many years as a kid in rehab medicine post polio. I didn't see many doctors. I saw a lot of physical therapists, saw a lot of occupational therapists. They did great work, and they absolutely have my respect and admiration and so on for what they do. But getting into this battle is partly a battle about privilege and title when you're in healthcare settings, that people want to command more respect. There may be a money angle. People may start to get paid more. Doctors get paid more than I do, although that isn't always true. I've been looking at some hospital pharmacists lately. They're doing pretty well. But it could be partly a pay dispute, if you will. But at the end of the day, let's keep the focus where it should be. It's not supposed to be a fight among doctors and nurses and social workers and chaplains and whoever else is there about who's prestigious and who gets to be called doctor. It's what do the patients think? What's in the interest of patient understanding? The other thing is a bit of a turf war that goes on. I think dentists, nurses sometimes want more authority. And for example, I'm a proponent of letting pharmacists give vaccines. We don't have enough people to give them. I think you can get trained to do it, and great. So their authority expands beyond what it once was. Some nurses want prescription authority. I think that might make sense if you're in rural Alaska and you're not going to see anybody for 500 miles, and maybe you don't even have good Wi-Fi. This is who you've got. You need basic medicines. I think they could probably, prescribe your diabetes medicine or the sort of common ailments. But as we say, some of this is turf. Some of it is being able to have a nurse anesthetist do what a fully trained anesthesiologist does, which I don't agree with. I think there are training differences that make outcome differences. But at the same time, there are areas in our healthcare system where we're stretching authority. Doesn't mean we have to stretch the title, but we can stretch the authority to meet gaps and access issues.
Any of our listeners can easily tell that when you discuss this topic, just as you did in your writing and in your video that you created, that you're talking in a very respectful manner, and there's no nurse bashing or any real negativity coming from here. So were you surprised, considering the tone that you've taken, at the pushback and the comments? Maybe you didn't look at them, I don't know, but as when I've written about these topics, there will be hundreds of comments that are quite strong and critical. I'll just read one for you from Anne Marie Ball, RN, BSN, MPH, who says, "This has got nothing to do with medical ethics. It's all about power, ego, money, and good old-fashioned misogyny." Now, reading that, you don't strike me as a misogynist or an egotist or someone that's just getting. You're a professor. I doubt that money is a big, huge factor for you. But how do you respond to these kinds of comments?
Well, look, partly there's some merit in that criticism. There is ego and prestige claims on the line. I wouldn't deny it. I just think they're misplaced. Again, it's your work that gives you the honor and the prestige, not your title. I think that at the same time, there was a lot of pushback, and a lot of people said, you don't understand what this advanced nursing degree is or what goes into it. And for some people, it is a lot of work, and it can be very clinical, and I get that. But at the same time, that doesn't mean that you become a physician privileged to do what MDs do by doing an advanced degree. as I keep saying, I have an advanced degree. I spent 7 years getting a PhD and going to a lot of classes. It was pretty miserable labor, and you had to basically get a book published to get out of the PhD in philosophy. But I don't prescribe medicines, and I don't run around checking people for papilledema, and I don't do medical things just because I have an advanced degree. If I want to do doctor things, I'll finish medical school.
Well, I always find it interesting when the sexist card gets played and the misogyny card, considering that now more than 50% of medical students
my medical school class is pretty female.
Are women. Exactly.
Yeah,
it seems like women doctors get really fired up and passionate about this issue. First of all, I can't tell you how many times we walk into a patient's room and we're addressed as nurse, or, the doctor never came in to see me. I kept seeing that nurse all the time.
Yes. No, I hear it in the other direction. Mm-hmm.
So yeah, so just pointing out to anyone that's saying that this is a sexist issue, the reality is nowadays, guess what? Women can be doctors too, and
nurses
can be
are
nurses.
The male nurses running around the NYU hospitals a lot. I would say they're not a majority by any means, but I'll bet 15%, something like that. You can't presume just because someone is male that they're not a nurse, that those days are gone. No, I don't think, flat out, I'll say this debate, this fight, this argument has zero to do with misogyny, sexism, gender issues. It just doesn't. Those are not what's fueling this. They may fuel some other things, but they don't fuel this issue.
It seems to me that as with the use of the term provider, the upgrading to doctor for non-physicians is really sort of a way of trying to equalize or level the playing field so that we're all the same. I see it as a way that organizations that would like to pay less money or substitute for physicians are able to show patients, no, they're just as good. Don't worry. And they can pay them potentially less, and the patients may not know any better.
Yeah, no, I agree. That's what I meant when I said there's a pocketbook issue here. It may be that third-party payers or clinic directors or people looking to save money are able to hire someone slightly cheaper to do the same work and get away with it if they can also start to fudge terms like provider, as you say. I'm not a big fan of providers. I am a big fan of particular people, nurses, doctors, physical therapists who give care. And I'll tell you another term that I don't want to be called. I don't want to be called a consumer. I'm a patient. And I sometimes, if I'm in research, I'm a subject. I could be a participant. I'm all right with that too. But when I start listening to people converse about providers and consumers, I think that language belongs over in real estate and in buying stuff at Walmart and shopping online, but it's not healthcare. Everybody in healthcare who provides care should be seen as doing professional work. I think they all are due respect. When I hear about nurses getting threatened or violence in the hospital against healthcare doctors and nurses, it really bothers me because that's the altruistic, caring side of humanity that I don't think deserves any of that. But yes, payment, money, savings. Look, if we really want to talk about the threat about who's going to be called doctor, you know what it is?
AI?
Yes, it's the chatbot. So the cheapest way to see the title doctor thrown around is by all the private equity people who are pushing, get your mental health care online, get your drugs online, see Dr. Chatbot, and you'll be fine, and you don't have to get out of your house, and it's cheaper. That's where the fight is going to go, and I resist that. I think Dr. Chatbot should just be a chatbot or AI who can assist and augment, but you need the care provided under the supervision of a healthcare professional. I'm not ready to see Dr. Robot myself. So if we really want to talk about where that fight's going, it's right there, because that's where you save money.
I think it's really good that we're weighing in from a bioethical standpoint, because what I always keep going back to, I had to pull my old ethics textbook out, which is the whole concept of medical ethics of beneficence and non-maleficence. Of course, we have patient autonomy there. Sometimes I think that's going too far, where I'm seeing, IV infusions and full body MRIs saying, well, that's what patients want. Well, we have to remember patient autonomy is one of three. We have to factor beneficence and non-maleficence. And I really think this isn't just NPs and PAs. This is also, I'm speaking to physicians. It's time to push back against that and to really revisit our medical ethics.
Yeah, you're talking little bit to the choir here, because I've been writing for many years that the autonomy pendulum has swung too far. Yes, those other principles come into play. And also, look, there's a knowledge difference. There's a gap. I can't say, I feel like I have a headache. I'm going in and you will now give me an MRI, because that's what I saw online was the best thing to examine your head or something. I don't have any knowledge. My informed consent about what to do about headaches is in the hands of others. So I'm going to bring up another word. I think there's some room for some paternalism in medicine. You just have to accept the idea that sometimes an expert knows more than you. Now, that's something that our society isn't so comfortable with. We see it getting kicked around in public health. People are backlashing against climate change experts, COVID experts. There's a lot of rejection saying, I know best, I can decide. Well, you don't know best, and you can't always decide because there are vast areas of specialized knowledge. I've been privileged enough to hang around medicine for 40 years. I don't claim, again, to know, what experts in medicine know, but I've seen enough to know what they're expected to know, and it's quite a bit. So you're right. Just because I say, I want this or I want that, it isn't a restaurant. And I'm not supposed to be ordering services from someone who then is obligated to deliver them to me. I think you're right. Autonomy is getting us in some trouble too. It's a cultural thing, not unique to medicine. But yes, we have to be careful about just saying we do what the patient says.
I find myself thinking a lot about paternalism, in that I was trained during a time that we're definitely away from that and more about shared decision making.
Mm-hmm.
But I totally agree with you. I think the requirement where we have to almost coddle people, I think that must be contributing to physician and clinician burnout, because there is this constant sense that you have to defend yourself and justify and explain and over-explain and argue. And it's, frankly, it's exhausting. And absolutely, COVID has pushed it even farther. But even outside of that, I do find that that's something that I think is very fatiguing for doctors. Not that I want to go back to a completely paternalistic approach,
no. But more
I agree.
The worst area I can think of is end of life care. So we have all kinds of things being done because families or sometimes patients demand them, insist on them. People say, I want everything done. The doctor is there, and I know this because I spend most of my time either in ICU or palliative care settings, but we know that it's futile. We know that it's hopeless. We know that we're going to hurt the patient if we continue to do aggressive, invasive things to them, and we can prolong suffering in ways that shouldn't happen to a child or an adult patient. We don't speak up enough and say, look, this is the end. We've got to switch to palliation, emotional support. We're not going to abandon you, but this notion that we're going to keep, resuscitating you, or we're going to look for a pig heart to put in you, even though you have 9 other morbid diseases and are 89 years old. That's an area that has us in trouble, because you know what? It costs us a fortune, and it produces a lot of unnecessary suffering.
Well, thank you so much, Professor Caplan. I really appreciate your time and you weighing in on this really important topic.
Yeah, it's a good subject.
I hope you've enjoyed this podcast. If you'd like to learn more about the topic of non-physicians in healthcare, please get my books, Patients at Risk and Imposter Doctors. Both are available at Amazon. And if you're a physician and you'd like to learn more about getting involved in our mission, which is advocating for physician-led care for all patients, and truth and transparency among healthcare practitioners, please join our group. It's called Physicians for Patient Protection. Our website is physiciansforpatientprotection.org. And if you like this podcast and you have an idea for a topic or you'd like to appear on the podcast, please send me an email. You can reach me through my website, patientsAtRisk.com. Thanks so much, and we'll see you on the next podcast.